Manish, what's your interpretation of all this data?
Yeah. So there's been a lot of data that's been reported, as Kohei just reviewed, and I'll highlight just some of them. So and I'll start at the third line and move up. So in the third line setting, for PD-L1 positive tumors, pembrolizumab is in fact approved for gastric cancer, and the approval is gastric and GE junction. In the second line setting, based on your data, which was unfortunately a negative study, pembrolizumab is not approved. So we don't use immunotherapy in the second line setting outside of mismatch repair deficiency. So in the United States, if you're mismatch repair deficient or MSI high, then that's when you should use immunotherapy in the second line setting. And that's not unique to gastric cancer, but all solid tumors. So that's the second line use of immunotherapy. In the first line, which becomes a little bit complicated based on this study, I think the first question is, should we combine immunotherapy with chemotherapy? And that is a resounding no. There's no evidence that that's effective. So the standard of care for most patients remains chemotherapy, a doublet combination, as we've discussed. The study did have a unique feature for PD-L1 positive patients where it was technically non-equivalent based on their study design. And it was about 500 patients comparing PD-L1 positive tumors who received pembrolizumab versus chemotherapy, and there appears to be a non-equivalence. I don't know if that's going to be practice changing because of the points that Kohei made about the acceptance of detriment of effect. So I think we'll have to wait and see. I personally probably wouldn't use pembrolizumab alone because, remember, most gastric cancer patients, at least in the West, they're diagnosed with advanced disease, they're symptomatic. If we don't actually achieve a response, then we may not be able to continue treatment. And in fact, in this study, only about 50% of patients in either arm receive second-line therapy. So it's an important point for me that I think we need to consider the patient as we're making these decisions.
Absolutely. David, what's your take?
Yeah, I think Manish summarized it very, very clearly. But I think to emphasize, all of these studies show late benefit for immunotherapy. I mean, the curves don't separate until late, and many of these patients fail immunotherapy early. So I think at least the indication in the United States will remain MSI high second line, and chemo-refractory PD-L1 positive gastric cancer we can consider the use of pembrolizumab. I take a little bit of an issue with this non-inferiority claim of pembrolizumab monotherapy because if you look at the progression-free survival, 70 to 80% of patients get a few doses of pembrolizumab and they fail it, and they go on and get chemotherapy. So arguably you're comparing chemotherapy with chemotherapy because almost all the pembrolizumab patients are getting chemotherapy very early on. Now, to argue a survival benefit for upfront pembrolizumab, the problem is it wasn't a crossover. So all the patients that got pembrolizumab upfront got pembrolizumab during the course of their illness. If you look at the chemotherapy alone patients, 5 to 10% got pembrolizumab. So you really can't make a survival comparison. And I think to Manish's point, these are sick patients. So you have a 25% response rate at best. And so you're permitting a 70 to 80% fail rate in a sick patient. So I don't think this is going to be practice changing. It's going to be interesting to see what the regulatory take is on this. I think upfront pembrolizumab is going to be a highly selected asymptomatic patient with a high CPS score, maybe someone that's had prior gastrectomy, that's had prior adjuvant chemotherapy. But I think, to me, this trial does not change the current standard of care, which is late-line use of the therapy. And we'll have to see what other ongoing upfront studies of combining chemotherapy with checkpoint inhibitor therapy yield.
I completely agree because I was deeply involved in the trial, so maybe there is some bias, but I completely agree. Even if available, I may carefully select the patient based on MSI high, CPS score, and patient symptom and general status. So very selected patient only can receive pembrolizumab monotherapy in first line.
So aggregating everything, so maybe a very selected patient with all of the, I'm going to respond to immunotherapy markers of.
If it gets approved.
If it gets approved.
Outside of a study, I would not do it.
Yeah. So high CPS, MSI, asymptomatic, minimal disease to give enough time to respond if it gets approved. So in general, don't do it in first line. In second line for MSI high, would you do CPS greater than 10?
It's indicated
No.
for anybody who's MSI high, independent of CPS.
But if you had a CPS greater than 10, would you ever consider using a pembrolizumab in the second line?
No, we have a negative randomized trial showing it's
So
not
actually,
better.
we cannot use it in Japan.
Okay. And also the wrong comparator, right? We should have been using paclitaxel plus ramucirumab. Yeah. Yeah. And then third line in the US for PD-L1 positive patients.
Right.
And in Japan,
Without patient enrichment by biomarkers.
Yeah.
But we have a 3 options in Japan. TAS1, maybe same in US, TAS1, 2, and nivolumab and irinotecan. So patient selection might be very important. If I have a good PD-L1 score, the high expression, maybe I can start with a nivolumab first. But if patient had a very large tumor and some symptoms, I usually start with irinotecan first. So it depends.
Yeah, and TAS-102, I think in the PD-L1 negative patients would be now the standard third line treatment. Irinotecan, TAS-102. PD-L1 positive, we have the approval of pembrolizumab to consider.